And as tissue heals, it contracts. And when it contracts over sharp bone, you have inflammation, ulceration, and then the third one would be sequestration, which is dead bone.
Any of the extractions we have that have the potential for becoming surgical, we should have these in a tray setup. But we never can fully predict what's going to happen. Even those that look simple and straightforward can become fairly traumatic and difficult. These three drugs all have synergistic effects of sedation with the patient. Put the 301 down there as far as we can get it. We got part of it there. Squeezed on the tooth and infection came out of the nerve chamber. We need to make sure that after we do this, we profusely irrigate. It's loose as a goose, and there it is. Okay, that's great. It's a pleasure for me to join with the Video Journal of Dentistry to present this educational program on exodontia. We're going to talk about basic procedures. We're going to talk about procedures traditionally done by general dentists in their offices. We're talking about taking out teeth, some of which are easy to get out, some of which are more difficult. Hopefully the things we discuss will make these procedures more comfortable for you to do, easier, and hopefully you'll be able to do them more quickly because of the principles that we cover. Now, I'm going to make certain assumptions. I'm going to make one that you use informed consent, and this will be one of our handouts. I assume that you know your patients, that you've reviewed their health history, that you have their vital signs recorded in the chart, that during the surgical procedures you'll take those vital signs again, that you have an emergency kit in your office that includes positive pressure oxygen, and it's readily available. I'm assuming as well that you know your patient's emotional status, their psychology. These things really come to bear, especially when we're doing the more invasive procedures like surgery. I'm assuming also that you have an appreciation for the anatomy of the patient as it relates to difficulty of surgery. For example, if a patient has a more tapering, longer facial form, the surgery will definitely be easier than if a patient has a more compact facial form. Why is that? Well, if you consider with the taller patient, the more tapering form, intraorally you can palpate nearly to the apices of teeth without coming to the mucobuccal fold. There's a high palatal vault. You can visualize almost the entire tuberosity. There's a low floor of the mouth. These types of things make it much easier to do a surgical case than the opposite. I am assuming also that you have good x-rays of the case that you're going to do, that they show the root structure, they show whether or not the bone is dense or not. And of course this relates to age as well. Of course, as you know, the older the patient, the more difficult potentially a given case will be. You know, we all go into surgery expecting that it'll work out okay, that it'll be routine, that it'll be simple, if you will. And most of the time it will be. But we never can fully predict what's going to happen. Even those that look simple and straightforward can become fairly traumatic and difficult. Now, before the fact, before the surgery, if we can tell by the x-rays and the nature of the patient and so on that we're going to have problems, it's probably in the patient's best interest and ours that we refer that case. But assuming that we decide to go ahead with it, we just never know what's going to happen. In fact, 10 to 20% of all extractions that are done that appear routine on the surface will become surgical. That means we need to be prepared for any eventuality. We need to be prepared for the ultimate surgical case that may develop. And the way we do that is we need to have the right instrumentation. We need to have ideas in the back of our mind of, if this doesn't work, well, that's okay because we can do this. We have a different instrument. We can remove a little more bone in a certain place. We can do something to the tooth, maybe a section cut, maybe a purchase point. We have not only plan A and B, but we have C and D, and then on through the alphabet, so that there's lots of options available to us. That's the only way these extractions will become predictable. As we begin our discussion of difficult extractions, if they all could be this easy, then we'd have it made. But unfortunately, that's not the case. We have a lot of problems many times when it comes to extraction. Some that should be easy and turn out that they're not. This is the type of case that most generalists would not attempt. It's something that would be referred to a specialist. But you know, we don't always know which cases to refer. Some people are hesitant to make a releasing incision to reflect a triangular flap, to reflect the periosteum to get access to bone or root. But in reality, it's no more difficult than peeling an orange. Here, as you can see, peeling it gives you access to where you need to be. It's the same in the mouth. Make the incisions, reflect the flaps, put them back when you're done, and it gives you access and availability to the surgical site in a way that limits bleeding and allows you to expedite the surgical procedure. There are 17 different things I'd like to mention, things that if implemented will help expedite a procedure, will increase your comfort zone, knowing that if one thing doesn't work, that within a minute or two you can quickly go to something else that may do the job for you. We're talking about things such as using the fine suction tip for the upper bicuspid fractured roots, something that will enable me to see clearly clear to the apex of a very delicate socket. Endodontic file. This is a method I don't use very often, but occasionally to use a 30-35 file into a root tip that may be somewhat loose will help facilitate removal. Straight elevators are the workhorses of exodontia. They're the pre-luxators. They are what luxate prior to luxating a little more, perhaps, with a forceps. Root tip picks. But when I say root tip picks, we need small and large for small roots, and then a different set for large ones. Straight handpiece traction, where a straight handpiece, number 6 round burr, goes into a root that you have access to, and then is stalled, using that with traction to remove the root. The forceps is another excellent tool for root removal. Section cuts, followed by tooth fracture. Using purchase points for elevators. Inter-radicular bone removal, removing bone between the roots in order to be able to place an elevator, particularly in molar areas. Pennant-shaped or curved elevators. Shaving down one side of the root, we can actually remove some of the tooth rather than the bone, conserve some of the bone, and have a less traumatic procedure for the patient. Cutting a single root in half, lengthwise. Bone fenestration at the root apex. Buccal bone removal or buccal plate removal. Mesial or distal, what you might call interseptal bone removal. That is, between the teeth. Elimination of the root by attrition, particularly in the case of ankylosed roots. It may be the only way you can get it out is to dust it away, to drill it away. Leaving the root. This is an option and certainly a viable option. It may be that we've considered and even tried most of the other ones before we finally come to this. But it's not bad dentistry to occasionally and under certain circumstances to leave a root tip. It should be fairly short. For example, Laskin suggested it be under 5 millimeters. It hopefully is not infected. It may be by an important anatomical entity such as the sinus or the mandibular canal or the submandibular space. But if that is done, of course, there's certain things we do such as noting it in the chart, informing the patient of that, and then following up at a future date to make sure everything's okay. Let me show you some instruments that will make it a lot easier to do the types of things that we're demonstrating in this particular tape. First of all, if we want to look at some of these supplies, we have a bouffant cap. Sure, you can use hemostats and towels and wrap them around the patient's head, but we found this to be a very simple and easy and inexpensive way to get the hair out of the field. Another thing that we do is have the patient rinse preoperatively with chlorhexidine gluconate with Paradex or some of the other brands that are now on the market. This, in effect, reduces the magnitude of organisms in the mouth substantially. We have them rinsed for approximately 2 minutes. Another thing that we do and have in the way of supplies are these sterile drapes. They become pre-packaged. They're approximately 18 by 26 inches. We use one over the patient, and then we use another one under the sterile surgical instruments. We talked about the basic supplies. These are the basic instruments, and I feel that for any of the extractions we have that have the potential for becoming surgical, we should have these in a tray setup. I have these, most of these instruments are bagged, ready to go. Even if it's a so-called simple extraction, these are the instruments we have ready. The first instrument that I want to show is the surgical high-speed handpiece. Many oral surgeons are critical of general dentists doing surgery, and one example they use is that they use their conventional high speed and blow air into the surgical field, potentially causing air emphysema, which could be life-threatening, as air may get into the fascial planes of the neck and down to the mediastinum, causing mediastinitis. Well, we can get around that criticism by using a surgical handpiece. We've got fiber optics. We have a little portal right here through which a stream, not a spray, of water emerges and hits the cutting portion of the burr, splashing then into the field. It also accommodates a surgical length burr, and in this case on here we have a 1702. 702 is the conventional burr. 1702 just indicates that it's end cutting. This is a Midwest shorty, but this is very effective up at the 30,000 RPM range. Again, this has a 702 straight handpiece burr in it that is very good for surgery. To look more closely at the surgical area or to retract the cheek, we definitely want a mouth mirror. Next is the Bard Parker, and the blade that I most generally use is the Bard Parker number 15. The instrument we have is a Molt number 9 periosteal elevator for most of the things we're talking about with heavy-duty flap retraction, reflection and retraction. We need something like this. This one usually initiates the flap, and then as I turn it over here, you see the wider end to continue it, lifting up periosteum from bone. This instrument is the Selden number 23, your primary instrument to hold the flap back. The 301 goes hand in hand with that 702 burr. In fact, if you make a section cut in a tooth with the 702 or 1702 burr and you don't make it too wide, you can follow up with the 301 elevator. Put the 301 in the skinny way and turn it to the wider dimension, and it will cause the fracture that you want to separate a tooth in various parts. But there are times when you need one that's a little bit wider, and that would be the 34S as one example. This is called a Cogswell B, and it's similar in its angulation to a crane pick. It's used to put into purchase points, which are holes in the root or the tooth adjacent to bone. It allows good leverage to, once it's in that purchase point and fulcrumed against bone, to be able to cause the withdrawal of teeth or roots. As you can see, we have on this side the 151, and over here on my right, the 150, they're called universal forceps. And they can be used, the one on my left, the 151, to remove all teeth in the lower arch, and the one on the right, the 150, to remove all teeth in the maxillary arch. This is the Mayo Hager 6 1/4 inch needle holder. It's good for the anterior of the mouth, and it's also good for the third molar area. It's big enough to hold the needle securely, and it gives me good visibility around it. This one is my surgical scissor. It's called an S15 Sullivan. This one effective not only for cutting sutures, but also for cutting soft tissue tags as needed. These are my Addison Brown number 43 tissue pickups. They give you control as you're removing such things as tissue tags. You can hold on to it and use your scalpel to excise it, or scissors, or what have you. This is a surgical spoon curette. This particular one is the Lucas 86. Now we have a couple suction tips. This one's tapered, and as a result it doesn't plug up as much as those that are not tapered. They're very inexpensive, they're autoclavable. Each case that you view on this tape, we will have used a mouth prop. We use them with third molar surgery, we use them with even just 1 or 2 extractions. I think it's critical to use something like this to help protect the temporomandibular joint from undue stress and strain. These are not in our basic tray setup, they're bagged separately, they're available if we need them. For example, there is the 17 forceps, which is designed for lower molars. Another one for lower molars, of course, is the number 23, which is the cow horn. I know you're all familiar with that. As we move along for upper molars, there's the 53 R and L, and you can see there's one portion of it cups the palatal root, whereas the other side gets into the furcation of the buccal roots. And those are pedo forceps, and I use these many times with adult teeth on adult patients, particularly for single roots or for lower anteriors, for example. Better control with these smaller instruments. Root tip picks. We definitely need root tip picks, but let me say not just one set, but rather 2. This is the larger variety. These are the Heidbrink 2-3. The other set would be the West 2-3, and you may have your own numbers and own examples. Notice how delicate these are. For a very tiny fractured root, maybe a couple of millimeters long, where you need something more delicate than the ones I just showed. Next we have criers. Now, as I've mentioned, crier elevators, east-west, flag, pennant, whatever you want to call them, they're indispensable for surgery. I need them for all difficult cases. Now, as far as supplemental instruments go, let's look at a few things that help smooth bone, particularly during alveoplasties. First one is the bone file, and this is a 2X, both push or pull, rounded on one side and then flat on the other. Another instrument for dealing with bone, be it torus removal or alveoplasty. I'll hold up these 2 bone burrs by Brasler. The one I'm pointing to right here is an H251E for use with a straight handpiece, and an H351E over here, a little bit smaller. And we must mention rongeurs. It's just which one do you want to talk about? Well, this one happens to be the R1 Hugh Freedy, both end cutting and side cutting, a feature you definitely want. And then the fourth method of smoothing bone would be to use either your high speed or your straight handpiece and a small burr like this, which is the 702 or 1702. Now, I showed that white suction tip earlier, and that's great. That's one we use almost all the time. But here's one that's half the outside diameter for getting up in that first bicuspid socket to see that fractured buccal root that you broke off. This one is only 2 millimeters outside diameter instead of 4. Gel foam, here's our bottle of size number 4, with a few drops of ophthalmic, and certainly not the ointment form. You would never use that in a socket because it retards healing, doesn't resorb, and anything with petrolatum, Vaseline, you'd never put in an open socket. In the event we do get a dry socket, we're going to use probably, or I would, something like new gauze. This is a 1/4 inch by 5 yards, plain packing strip, to which we add some Sultan or Getz dry socket paste. and then add a couple drops of eugenol to that. Rinse the socket out without anesthesia and place it gently, carefully into a dry socket void, and this will take the discomfort away within a matter of minutes, actually, and of course it needs to be removed within a few days. Another entity that we might use for bleeding problems, if we have a lot of blood coming from a socket, is Surgicel, which is this hemostatic agent, oxidized regenerated cellulose. To put a small amount in, large amounts generally need to be removed, but small amounts can stay in the socket. We suture over the top of it. And gel foam is something else that you could use as well. In my office, I frequently use oral sedation and have for a number of years. This one, some of you may recognize as 10 milligrams of Valium. Another here, this capsule, is Mepergan Fortis, which consists of 50 milligrams of Demerol and 25 of Phenergan. Now, you put these together, these three drugs all have synergistic effects of sedation with the patient. The Demerol also raises the patient's pain threshold so that they don't notice the injections so much or other minor amounts of pain that they might have during the procedure. Together then they work very, very effectively, sometimes as well as IV light-conscious sedation would work. So in addition to these oral medications, we will also put nitrous oxide on the patient, somewhere from 30 to, say, 50%. Actually, we don't have the ability to titrate as you would with IV sedation, but in a sense we can, because we titrate with the nitrous oxide. In terms of local anesthetic, I'm pretty traditional. I use xylocaine 2%, 1 to 100,000, sometimes going to the 1 to 50,000, but not if I'm going to use very many carpules or if I anticipate that. And I will often mix with that the long-acting anesthetic, like Marcaine, or better yet, in my hands, Duranest. I prefer Duranest because it has a faster onset. We do use the interligamental quite a bit. It has a 30-gauge needle, 1 inch, but I engage this into the periodontal ligament space, one for each root that the tooth may have, give it maybe 10 or 15 seconds of solid back pressure without backflow in those areas, and then we usually are able to go right ahead without having to wait to reblock. So I'm a little reluctant to give multiple blocks. I'll give one the best I can, and then I'll oftentimes, for expediency and for simplicity, use this instrument. Occasionally you get that hot tooth that where nothing works. I mean, you try your block, you try your infiltration, even perhaps interligamental syringe, and you just need something else. Let me present this as an option, this being the intraosseous injection technique. The kit is composed of a few different things. Here you see the drill on the right and the needle on the left. The needle being very short. The drill doesn't really look like a drill. You can see a stop there. First thing I do is to use topical, as Malamed points out, with a good minute or minute and a half of placement of the topical anesthetic. You can get 2 to 3 millimeters of anesthesia. Once we've anesthetized the mucosa with the topical, then what I'll do is take this needle that comes with the kit and blanch the soft tissue. Then it's a matter of putting that little drill that you saw earlier in your contraangle, and at a point between the roots then, to use that little device, that little drill, if you will, penetrate through the mucosa and press on cortical bone until it breaks through. And you'll feel that. It'll lunge somewhat, and you'll know that you're into the trabecular area. You're into the cancellous bone between those two roots. Eyeball it in such a way that you miss the roots, but you get it in between the roots. Now we pick up the syringe again, and using that same needle that we used to blanch with a minute earlier, we now go into the hole that we've made with the drill and inject half, 3/4 of a carpule into the bone at the apices then, or in between those two roots. And I'll tell you what this does. It numbs up those two teeth. It numbs up the one on either side. Not necessarily, however, numbing up the inferior alveolar nerve, so you usually don't get lip numbness here. You don't get tongue numbness. You get tooth numbness of these two teeth. It works very well. Antibiotic coverage as needed. Postoperatively, I frequently give the nonsteroidal anti-inflammatories. Occasionally, some of the Lortab hydrocodone with acetaminophen type medications, but rarely, if ever, will I go to the Schedule II narcotics. Now we're going to present to you several different cases, different patients, to demonstrate some of the things that we've discussed so far. When someone needs all of their teeth removed, for an immediate denture, for example, the way I prefer to go about that is to take out the posterior teeth first and then, say 2 months later, take out the anteriors. This is superior, I think, from taking them out all at once. You have greater stability of your denture. There's less trauma each time you do it for the 2 times. There's definitely better occlusion, and it precludes the need for often remaking the denture. But there are times when the other way is better too, when the patient will only undergo one procedure and you need to do it all at one time. Some of these cases today are that type of situation. We want the face disinfected so that when our gloves touch the face, our instruments touch the face, we're not transferring organisms not indigenous to the mouth, such as staph or other types of bacteria, into the surgical field. So Susan, if you'd go ahead and do that for a couple minutes with the HipoCleanse scrub from ear to ear, from nose to Adam's apple. Now, with the patient hopefully anesthetized, what we're going to do is reflect cervical flap. Now keep in mind, we're going to retain number 30. So we want to do just a modest cervical reflection around 31 here. And then on the lingual as well. Next thing we want to do is do some luxation here with the 301. Now, we want to have the fulcrum of the elevator bone, interseptal bone. And as I'm wiggling, I can see that most of the movement here is the tooth in question, the second molar. And I don't see the first molar moving, fortunately, when I'm doing this. And I'm trying to luxate, which involves expansion of bone, disruption of periodontal ligament. I think that's all we're going to get out of this. Let's go ahead now with forceps. What I'm going to use is the 23, which is the cow horn. And the roots are pretty straight. That happens. And when it does, you just have to deal with it. The tooth is weak. We were using luxation forces, but still the tooth fractured off, kind of between the gum line and the bone level. Actually, on the distal, it's quite a bit below the bone level. What we need to do here is not continue luxating. We've already done that. We need to divide and conquer. We need to separate those roots. It's futile to continue doing anything with them intact that way. We're going to use the Impact Air 45 surgical handpiece that does not blow air into the surgical field to separate the roots. Now the 301 is in there. What we're doing is affecting separation of the two roots so that we're dealing with two entities and not one. If we try to engage that root with this size crier, or east-west, whatever you want to call it, you can see the fulcrum is actually the tooth in front. And yes, we could maybe angle it, but then we lose our mechanical advantage. It's better if we can use the small crier. And now with the smaller crier, where we fulcrum actually off the other root, or maybe the interseptal bone instead of the tooth itself. We're trying to engage that root. I'm going to remove some distal bone here to get a point to insert an elevator, so that it's I'm not only trying to get it from the mesial aspect, but from the distal aspect as well. And using distal bone as a fulcrum, we're going to work on this coming from the posterior. There it is. We removed some bone on the distal to enable us to engage the opposite crier from the distal aspect in the distal surface of the distal root, and here it is. So go ahead and suction that out if you would. It's not working. We're going to have to reflect the flaps. Okay, in order to have access, visibility of this mesial root of the second molar that's fractured fairly deep, we're going to reflect a triangular flap. Now the question is where? Ordinarily it's one tooth away, and by that criterion it would be right here. But we're going to be taking out this tooth in a few minutes, and it may be that we would need a flap for it. And if we can complicate things unless we plan for that contingency, number 28 is going to remain. So just to plan for the future in a few minutes what might happen, we're going to make the release and incision on the mesial of number 28 and then reflect on back. We see the release and incision on the mesial of number 28. Now with the sharp periosteal elevator, we won't make an incision with the scalpel along these teeth, but rather reflect with the periosteal elevator, in this case a molt number 9. This is very thin and friable right here where the incision is, so we need to be careful. As everyone knows, we do have a mental foramen and mental nerve emerging somewhere near the apices of these bicuspids, so we're going to be careful of that area as well. Okay, all this to give us greater visibility. I'd rather not remove this bone if I don't have to. So let's use the burr to remove inter-radicular bone between the roots to lessen the body's hold on that root. Now I can put this all the way down to the depth of the socket of the other root and know that I'm not going any further than that, but I can go from that point mesially across a width that I would guess would be the width of the root. Now by removing inter-radicular bone, we're not increasing the wound size at all, but yet we're removing some of the body's hold on that particular root. There it is. One thing that needs to be emphasized, I think, is that you don't spend more than a minute or two on any one thing. That's where people end up spending hours doing an extraction of a tooth. It's where they try the same thing for too long. You need to have a lot of different options and just move on to the next thing and not spin your wheels. Now, this to me looks like a tooth that is just ready to break, Susan. And I think by luxating here with a 301, we're probably luxating 28 as much as 29, so we don't want to do that. Similarly, let's try on this side. We can fulcrum a little against the molar because it's so much stronger, but if we use very much force, that tooth will just break off right at the gum line, just like the second molar did. I mean, the first molar will. So we forego extensive luxation with a straight elevator and go right to a 151. Now, not to use traction forces for extraction, but rather just to luxate, and there the tooth just crumbled. But even though it is breaking, let's, while it's not broken yet, let's take advantage of this moment and luxate while we can. Now, by luxate, we're doing some rotational and some buccal and lingual. In fact, we should, as we go back and forth, not quick motions, although sometimes we'll do that, but more extended motions, like for 5 seconds or so. What we're doing is expanding bone, disrupting the ligament, and again some rotation. Well, even though it broke, it's luxated, and I'm glad now that we made that release where we did. If we hadn't, then we'd have a mess with multiple releasing incisions. Now we have a root that's fractured off at actually below the bone level on the lingual side, and a little coronal to the bone level on the buccal side. We've changed from a 151 to a 151S because we can see better, we can have more control. We've reflected the lingual tissue and the facial tissue. We're going to put the lingual beak right on the tooth, maybe right at the bone level. On the buccal side, however, we're going to place the beak actually a couple millimeters over bone to get a good engagement of that root. And we'll see what happens with this. Using some rotation, it wants to slip off mainly because of the way it fractured on the lingual aspect. Keep it clean if you would. We're going to try this, and it'll work or not, and we won't try it too long because we have other options. Let's go to those other options. And we're not going all the way to the apex with this. We'll go down maybe a couple millimeters and try again. This is bone that, by the way, will fill in. Maybe a slight concavity on healing, but not extensive. Just the width of the tooth and then down along the tooth. We've gone maybe 5 millimeters, 4 millimeters from where we were. Now, the tooth isn't rock solid. There is some movement. It's just that because of the way it fractured on the lingual, the forceps beak keeps slipping off. Even though we could engage well on the buccal, the lingual won't allow us to do that. And we don't want to continue down to the apex. We could, and that would get it out certainly. But we're going to try something else. We're going to cut, we've extended the burr out of the handpiece, out of the head, another couple millimeters. And we're just going to go across this tooth, quite deep. All right, now 301. See, the tooth is actually moving. Now, put the 301 down there as far as we can get it. Okay, we got part of it there. Okay. We'll try to get a purchase on this on the side. Even though only part of the tooth broke, let's use this opportunity to do some further luxation here. Let's make a purchase point down here into the root. We're going to use, with the space that we have for us, we're going to use the Cogswell B, and if you take a look at the angle on that instrument, you can see it's very beneficial for what we're doing right here. A straight elevator wouldn't do well, a crier wouldn't do well. There it is. Let's take a look at that root. So we tried a few different things. You know, things don't always work the first time. Right now we're going to take out these 4 incisors. Now, let's reflect cervically. You know, this patient probably should have had scaling with the cavitron. That didn't happen. It's okay. Would have been a little bit nicer. We just have to make sure that none of the calculus that I can see ends up staying in a socket. Now in this case, as we luxate, we don't care so much what moves, as long as it's not number 28 there. So if we luxate both of them, so much the better. Okay, so buccal, lingual, buccal, lingual, apical as well, if you like. Some rotational. Another principle we want to try to remember is to have your forces and forcep in the long axis of the root. Okay, we'll reflect the envelope down to the floor of the mouth and try not to go beyond that. If you have to, you have to, but I don't think we do. If you do have to reflect below the floor of the mouth, it opens up the possibility of contaminating spaces. We can see a very prominent torus here, that since this patient is going to have a partial denture, it would be very appropriate to relieve that. To not do so would make denture fabrication extremely difficult. Rather than shaving it off altogether, we'll just start off right at the normal contour that we would like. So trying to maintain the overall bony contour of the ridge. So it's the continuity is maintained from incisor region to molar region. Okay, let's get it out. Take that piece of bone out. Okay, now let's just smooth it off. We're almost done. With this bicuspid, we are using the 151S. We decided not to use the straight elevator at all, and that's because we felt it would dislodge the crown on number 22. So we're using this 151S for luxation with rotational movements and buccal lingual. Okay. First, let's remove some granulation tissue from this area. Now let's do the distal of that bicuspid. So important to get this out. Okay. Barred particle. Suction. Okay, section of it. Okay, that's all right. Okay, suction. We're now going to remove the impacted or unerupted canine, number 27, that according to x-rays is right beneath where number 24 and 25 were. We're going to start by making another releasing incision right here. To give us the access and the visibility we need. So we're going to section it right across there. We'll keep a handle on it here. There, Owen. So we've removed the crown. We just looked at the x-ray to confirm the angulation of the root, which is to the right and down. We're going to make a little purchase over on the left side in which to insert an instrument such as a Cogswell bead. Let's put a purchase point in it right there and try to take it up. All right, we need to shave the bone off, or shave the tooth off so that it'll finish coming. Cogswell. Well, the fact it's loose is good. It just need to get out as quickly as we can. And now that we're down further on it, let's make another purchase further down. Okay. Came up some more. Section.
Okay.
That pieces out. Okay, suction that root. Okay. Put that piece right there. I only use, I think, 3 different types of suture material. This is the workhorse type, and that is the 4/0 silk. More important than whether it's 3/0 or 4/0 is the size of the needle. The 3/8 circle is what is important, and not to have something like an X1, which is the huge half round. Are you feeling something? And if you've ever tried to suture a releasing incision with an X1, you know what I mean. It's fine for the flap part, but when you go through the fixed side of the tissue, the X1 invariably will lacerate the tissue to death. Let's see, I don't think the FS2 will get all the way through in one swipe. Would you press on that? Yeah, great, thanks. Show this loop right here. And then turn it into a figure 8 and put the needle through.
Try one more continuous block and then.
So here we have the figure 8. The first thing we'll do is take the Bard Parker and excise the papillae that are diseased and that would need to be removed anyway. This will just facilitate that, expedite that. We don't want them there. They will just retard healing, their presence. So we're starting on the right side, and we have a bite block on the left side to help support the TMJ. That really goes a long way to lessen problems with the joint. So we'll work up to about the midline. It looks like we may do a frenectomy in the process here. We'll do the same thing that we just did on the facial, on the lingual aspect now. Let's go now with the 301. Would you take this crown that's coming off? Right there. As we would expect that it would. Some people ask me, which way do you turn the 301? Do you turn it clockwise or counterclockwise? Well, generally it's counterclockwise against the tooth that you're removing, but as Peterson points out in his book, Contemporary Oral and Maxillofacial Surgery, you can do it either way. There's a slightly different vector of force in each case. And certainly in this instance, you would do it both ways. And because those papillae are already severed, you don't really care if you smash them. Okay. If luxation is so important, whether it's done with a 301 or a forceps, or a 34S for that matter, expansion of bone, disruption of the ligament, loosening of the root, suction on the facial if you would, so that if a root does break, then it's so much easier to get out if it's been luxated. Okay, now we're going to continue luxation, this time with a larger elevator. Having luxated, we will now use the universal forceps in the long axis with buccal lingual motion, with heavier motion, heavier pressure towards the buccal, only because the bone is slightly thinner there. Now, in fact, the buccal motion here is the major one everywhere except the lower molars. On the lower molars, the bone is thinner on the lingual. This one probably won't be as conical. It usually isn't. Okay. Let's leave that one for a minute and go to the bi. Okay. These are only coming out this way because of the previous luxation. This one has generally 2 roots, and it's common to break one of those roots, but it's been luxated, and our force will be more to the facial than the lingual, so that if one of these roots does break, it would be the facial one, which is easier to retrieve and not as close to the sinus. Now, this tooth invariably is one of the most difficult. Long axis, some rotation, mostly buccal lingual, patience. It's common also to fracture some of the facial bone, causing sharpness and necessity for rongeur and a lot of bone trimming and bone loss here. Look how long that root is. What we're doing is cutting a dead tooth in half. I'm going through the furcation. I'm separating the palatal root from the 2 buccal roots, and I'm going to try to remove the buccals at one time and the palatal one intact. What we're going to do now is use the palatal root as a fulcrum and try to take out the facial. Her age, I think, is contributing to a little bit of bone loss. Okay. We'll go ahead and make about a centimeter long incision right here. You know, I think the scalpel is getting dull already just from what we've done, and it's not uncommon to need to change it. We've made a linear incision on either side, and now right against the periosteum. We'll go ahead and excise the frenum, and then connect the 2 cuts that we just made. Pull it. Okay. Let's just take a look at that now. So an incision on the one side and on the other, and then against the ridge, just up against the periosteum, and then excising the whole thing, joining the 2 V-shaped incisions. Let's go this far. forcep beak down on bone, en route. Rotational, buccal lingual. Now this is a canine, badly decayed. Looks like it may have had a crown on it at one time. Another long one. Wants to come buccally because that's the angulation of the palatal root. And we'll let it come any way it wants. It may mean that some of the facial bone is fractured, but we'll check that. There we have. In fact, we did. There's a little bit of facial bone, as you can see there. It's what we call bone latch. It's the bone that was holding those roots in and took a little bit, just a little bit of the plate. This is a surgical spoon curette. This particular one is the Lucas 86. Basically what you need is something that you can enucleate cystic lesions, granulomatous lesions at the apex. It's sharp, you can use it to scrape away granulomatous tissue, periodontal disease type tissue around teeth. You can use it for third molars, for follicle enucleation. First thing, rongeur for the papillae. Next, after that, it'll be rongeur for the sharp bone. These are for the papillae that did not come out with the teeth themselves. This one happens to be the R1 Hufredi, both end cutting and side cutting, a feature you definitely want. Very effective, even can help with soft tissue removal, but particularly smoothing bone. Basically what I'm looking for here is that the bone is smooth and blunt, maybe is a better word, when the tissue is over it, and I feel with my gloved finger. I don't want to remove a lot. I'm not looking for primary closure. I just want there to not be areas of irritation with the denture. After some smoothing is done with the rongeur, some of the major areas, then we go in and just fine-tune it with a push-pull bone file, which is the 2X. Hufredi is the brand that we're using. You don't need to remember which way it works. You can go either way. We need to make sure that after we do this, we profusely irrigate and not leave little pieces of bone in there. Okay, open now. Now that we've completed removing any granulation tissue either at the base of the socket or near the papillae or inflamed papillae, we've done the bone smoothing with the rongeur and also the bone file. Now we're suturing with continuous lock sutures. It's certainly quicker than interrupted. We don't want to have it so tight that it blanches the tissue. We aren't necessarily trying to have primary closure at all, especially with the denture on this to protect it. We can have areas that will form clots, especially with the denture protecting it as a bandage, if you will. And we'll get very
fine healing and quick epithelialization across these areas. People that feel like they have to have a linear incision postoperatively that goes from one side to the other, I think are probably removing more bone than is needful. The rule of thumb is to put one between each, the papilla area between the teeth. Okay, let's pull that out and do the locking. So, yeah, we try not to put them straight over the socket, of course, but in the papillae areas. Here we're turning the corner. I put in an extra one. This suture is called an anchor suture. We go through the mucosa on one side and then try to engage periosteum at a fairly high level, which we've done. And then come through the mucosa on the other side. What this will do is anchor the healing right next to the bone. Suction, please. Chandel is a 23-year-old young lady that has an unfortunate dental history. We can see the bombed out second molar, multiple carious lesions on the top. We've got a third molar that's completely decayed down below the bone level, carious second, first, canine. Looks like a lateral here that's at the gum line. There used to be a crown on that one, number 9. Number 7 and 8 are pretty well gone. We see again a couple molars here that have gross caries down into the root, and on the lower it looks like a third molar and a second molar. We're going to just put this piece of gauze back there, so if
you're going to feel it along the roof of your mouth a little bit, okay?
So if a tooth kind of falls back, it won't go down your throat.
Okay.
Generally, the first thing I like to do is just excise the tissue that should not be there anyway because of infection. It's just unhealthy tissue. We'll do a similar thing starting actually here between the first and second molar. We don't want to do too much because it may cause some bleeding that would make it difficult for us to see. But why don't we go ahead and luxate the whole quadrant. You don't have to take out the third molar first. It might be easier if the second molar were gone. So let's just kind of play it by ear and see what happens. Generally, second molar roots are fairly straight and conical. In fact, how's that? Let's just leave that one for a minute. What do you want to bet? This huge amalgam is going to come out. Okay, the 301 is certainly the workhorse of oral surgery. That and the universal forceps. Now, I'm going to go back here. This is just too small. It won't engage or do anything. What we're trying to do, again, as we've mentioned before, what we're trying to do here is to expand bone, to disrupt the ligament, to cause an inflammatory reaction occurring at the base of the root. Okay, this is one that looks like it could just break apart on us. Okay, a lot of pressure here. Now this patient is sedated with the Valium and Meprigan Fortis, which consists of Demerol and Phenergan. All of those have sedative properties. With the papillae cut, we will now use the periosteal elevator and make sure we have cervical reflections on the facial aspects. Not a great deal of reflection, but just enough that we can engage the forceps down to the bone level. Even with the cow horn, the crown is so decayed that it's losing my grip with it, but since it is holding somewhat, I'm doing a little luxation with it, even though it's probably going to break out. Let's use the 34S and see if we can't get it up. Okay, universal 151. Good. What we're doing here is luxation, buccal, lingual, buccal. Goes a little further each time, lingual. That's because bone is expanding. Buccal, lingual, a little figure 8. Doesn't do much. No broken roots. Even though we heard a crack, it was probably a little of the lingual plate as the tooth came out towards the buccal. But if it's attached to the soft tissue, even if it is fractured, we'll leave it. As you can see, we've made a buccal to lingual section cut right in the middle of that, lengthwise in the middle of that third molar. We're going to use the mesial root as a fulcrum now with this medium-sized crier, we call it. There's different names for that instrument. We're trying to engage the root, and it looks like it broke off. That's okay. And then we will do interseptal bone removal so that we can get a purchase, this wide area of bone between the second and third molar. Wash it off, if you would, a little bit more. First, let's use the 301, then the 34, and then the crier. Okay, we're going to use the crier. Sometimes we need to make a purchase, but we didn't need to this time, with the burr. It looks like using that interseptal bone as a fulcrum. It's loose as a goose, and there it is. Okay, that's great. We've got a portion of a root down there that we need to get out. There it is. We've got good engagement, long axis. I gave a little bit of extra anesthetic for this one in anticipation of one that might be a little bit harder. It was rotation, slight buccal lingual. See actually two roots fused together there. And then we'll go to another segment up to the bite block. Again, the papillae and on the lingual. Luxation of the anteriors of these incisors. Let's use the periosteal elevator here so that when we put the forceps in, it does not compress that tissue that we're leaving. Now we've switched from the 151 to the 151S. As we look posteriorly, that third molar is totally covered. The second molar is like the third molar was on the other side. We could start in the back and come forward, but I think I'll continue on around the arch as we're doing it. Here we have to start being careful of the lingual nerve. Basically, I'm removing a little bit so that we can see what we're doing when we get back to that point. This one we can't use the 301 on, obviously. It'd be very difficult to engage bone there. There's nothing to engage against. So we'll depend totally on a forceps for elevation, for luxation and elevation there. Actually, I'm sure we're using that other tooth as a fulcrum. But in this case, it doesn't matter since it's going to be removed. So we'll go buccally. But we have to be careful. With that thin bone, it could fracture out a large section lingually. But let's expand it a little bit. Buccally, lingually. And then rely on some rotational, and then finally some unscrewing figure 8 forces. Whenever I hear those sounds, I think, oh, do we have a root tip down there? We will see. We could use the 17 on this molar. We could use the 23. A 17 being like a 151, only with tips that engage into furcations. We could use the 23, which is the cow horn. We're going to use the 151 in this case. Sometimes you engage the forceps for a little more grasping power underneath it, the way I just did. Okay, fairly straight roots. Okay, we're going to try a long shot here. We've got that bombed out second molar. We're going to try with the forceps, not knowing if it's going to work or not. It could just mush out on us here. We've got some infection. We might need to use interligamental. Let's see what we got there. Now this is the last one. It's a wisdom tooth that's in pretty bad shape back there. Really nothing to grab onto. We could flap it more, and we may end up having to do that, but for the time being, I'm going to use a crier, this one, suction on the top of it if you would. There we go, clean it up a little bit. We're going to try it from where that second molar was and see if we can't engage that loose tooth. Let's see what came out. Okay, let's grab the suction. Give me a needle holder. Of course, if we get one of them out, then we're home free because we have an empty socket in which to use one of those instruments like the crier to get the other one out. Looks like that's just one of them. Yes, I can see another root back there. We'll use that same instrument, this time in the socket. And there it is. Okay. Let's work on the infection for just a minute. Now there's some there that's coming towards the suction. And the quickest way to get that out is with a needle holder. You pull it forward with the suction, and I'll grab it at the base. Okay, just hold it up in the air. Okay, there we go.
Occasionally we'll place cones in sockets to help prevent resorption. They're implants that are bone compatible and that help prevent resorption. They're not hydroxyapatite, but rather another material that is almost the exact ingredients of bone itself. It's a material that can be placed in the socket, and if we look at these pictures here, we see from the company that makes them, U.S. Biomaterials Corporation, that at the time of exodontia, then the flap can be reflected slightly to expose the area. There are 8 different sizes of cones that correspond to 8 different sizes of drills. The drills then are approximated size-wise to the socket. Whichever drill is most closely the size of the socket in question. It's put on a contra-angle handpiece, and with contra-angle drills, the socket is shaped, if you will, to exactly conform to the size of the implant, or ERMI, they call it, that will go in it. And with the patient that we were working with today, we only placed 2.
We'd like to put it in the canine area, but in the process of bone smoothing in order to get primary closure, which we have to have over these, so much bone was lost, thin, prominent bone in that area, that we can't use that particular socket. Now, our patient is sleeping and is startled periodically. Where did the countersink line on the distal? Okay, I think we're there. Okay.
These we use on occasion, particularly if we feel the patient won't have implants, conventional titanium implants in the future, but we need to do something to help maintain the ridge.
Now those are countersunk 2 millimeters below the crestal bone surface, and then we will close that with primary closure. Okay, now we're starting the maxillary arch on the right side to begin with. We've got a bombed out, grossly decayed second molar. The first molar is even worse. Let's remove the diseased papillae, come up maybe to the canine anyway, and then start removing teeth up to that point. So we'll come right to here. Well, we'll take out the canine too, so let's remove this papilla, incise this papilla. Okay, now with the periosteal elevator, the cervical reflection. You can see from looking at this molt number 9 that it has been sharpened. I periodically will sharpen it to make sure it does this quickly and efficiently. You have to have finger rest so that if it does slip, then it doesn't go very far. Since we got a little movement with the 301, we're going to the next larger straight elevator. So the first molar is the difficult one in this quadrant. We have gauze in the back just in case this decides to slip backward, which it could easily do. It's just hard to get a grip on this. Here we go. And we've got everything. I'm going to skip that first molar and go to the second bicuspid, mainly because it will give me better visibility for that badly decayed first molar. Again, buccal, lingual. Especially when we get to this first bi, I tend to lean more to the facial side, so that if there are 2 roots and one of them does happen to break, it will be the one on the facial, which is easier to get to, perhaps even with a fenestration. If we can't get the forceps on it without having it slip, since it's this far out, we'll just put it 90 degrees from the normal way, and bottom line is we get it out of there. So we'll use the root tip pick. Let me just feel down into the other socket first of all. Okay, we know about how far we are, and then I can feel this root right here. And so the first thing to do is to wedge alongside it. I have a feeling that that root is a little bigger than the root tip pick is good for. So let me see the other root tip pick. That's the one. Now if we luxated sufficiently, well, hopefully this would just pop out. But life isn't always that kind. I think we could do this for quite a while and probably wouldn't see very good results. Now, what do we do next? Put the burr down clear to the depth of that socket, and I'm not planning on going any further. To do so wouldn't be prudent because of the location of the sinus, but what I'm going to do is go down there and just with tactile feel, knowing where I am, come facially. We're removing inter-radicular bone again. Again, get my bearings. Here's the base. I don't want to go any farther than that, nor do I want to go lingually. Okay, what's happening here is using the back side of this, fulcruming a little bit against the socket, we've lost just a little bit of bone there. That's okay. Let's, since that happened, let's remove it. One thing about it, it should greatly enhance our visibility. There it is. So what we're going to try here is make a semilunar incision, and let's do that, shall we? What I would do would be to start at this point where you see the scalpel, maybe half a tooth away, and at the depth of the vestibule, and I would come in a semilunar shape, maybe 5 millimeters or so from the free margin of the soft tissue, and then come over about 1 tooth away on the other side. What we're trying to do here is to preserve some of that facial plate, knowing that there's a good chance that we'll do an implant there. And the last thing we want is to lose all that bone. So we want to try to preserve it if we can. There we go. How's that? Now we have to have some indication where the end of the root is. So we then take the x-ray, measure how far it is from the occlusal surface to the end of the root. Then we put that measurement, that ruler, in the mouth and try to determine that. Right now I think we're just going to make a guesstimate, and it looks like we're going to be right there. I'm going to make a little window. So after having done this, I've felt the end of the root, I've loosened it. A lot of times it'll pop right out. In fact, I've had it even pop out so quickly that it hits the patient on the tongue and they hand it to me. In this case, it's dislodged, but it's not just coming on its own. But because it is loosened, we can reach in here now with the root tip pick, whereas we couldn't do this before, and we can get it the rest of the way out. I don't have to tell Susan which thing to give me. She just knows. There are a couple different ways we could approach this. We could start with the criers. We could even section between the buccal roots. Okay, take that, Susan. I took out the 2 buccal roots, and it was hard to localize the palatal one, but by using the burr to wrap up and remove some of that soft tissue, and Susan, if you'd suction, come around at a better angle, I can see that it's still there. There it is. We can see the little black dot. It's the canal. But it's hard to get a purchase around that, really hard. What I'm going to do is just remove just enough bone to put the straight elevator around. Okay, that should do it. Now probably a 34, one a little bigger. I think it's moving it into the purchase we made. Now they say that this one is the most common one to go into the sinus. So there we go. Again, papillae removal. We really should deal with this frenum here as well. Okay, periosteal elevator. There's different schools of thought with regard to the canine, whether to leave it to last. Some people say that it's easier to get out if you do that, but I think it's also easier to inadvertently lose a lot of labial plate when you do that as well. The other school of thought is to take it out first. We'll split the difference here. We've got one out, We've got one still there. We'll go ahead and take out the canine next. Very difficult to luxate in this situation because of the way that the teeth are broken down. Some people would say it's because that lateral is still there that it helped maintain strength of bone, so we didn't lose it right there. I think the easiest thing to do in this case would be to remove just a little bit of bone on the facial and then use a pedodontic forceps. Okay, we just noticed that there's a piece of tooth from one of these anteriors that had fallen back and is on that piece of gauze throat pack. That's the main reason that we use that. We try to always use it. Oh, did you see that? Squeezed on the tooth and infection came out of the nerve chamber. Trying to pull it straight rather than move it one way or the other. If anything, a little to the buckle. The problem here is I think there's divergent roots. So we're okay. Two more. Okay. When you go too fast, they break. Sometimes they break anyway. Sometimes it's good to expand it and wait just a minute or so. And despite the divergence, it came out in one piece.
I'd like to thank the Video Journal of Dentistry and the Academy of General Dentistry for the opportunity of being able to spend this time with you. I think these things are needful and important. I've tried to share with you things that I do as a general dentist in my own office. And that's something a specialist does down the road with 4 or 5 years of extra training. These are basic, traditional things, principles that I think all general dentists should know. It'll enhance your practice to be able to implement these things in an effective way in your office. So if I've shared something with you today that can help to advance you along the learning curve, then I've done my job. I appreciate the chance. Thank you.